it to you. Okay, Miss Allen. So the recording has started and you may proceed. I'm going to mute while you're talking, okay?
Okay.
All righty.
So, good evening. My name is Erica Allen. I'm a student, a DNP student at Winston-Salem State University. And I just want to talk about the implementation barriers and strategies for framed text messaging in obese African American women. A little bit of background. Obesity is a global epidemic. It affects 93.3 million adults in the United States. Also, there's a direct correlation between obesity and chronic conditions. Some of those chronic conditions include diabetes, heart disease, kidney disease. And due to the comorbidities and frequent doctor visits and other things that go along with this disease, it could cost up to $210 billion a year. Obesity impacts quality of life. Some of the quality of life things can include not being able to participate in some activities, um, not not feeling good about themselves, having started to have some type of mental depression. Other things are obesity impacts quality of care around issues of weight stigma and bias, and also barriers to care. The quality of care around the issues and the weight stigma can include sometimes the providers just believing that the person is weak-willed or non-compliant, or sometimes just view them as lazy, so they tend to not address their issues or address the weight issues, which can lead to several other concerns. The rate of obesity in African American women exceed both national and state statistics. As you can see here in the United States, the total weight loss, the total amount of obese adults is 39.8. However, African American women is at 56.5%. In North Carolina, the total is 32.1%, and African American women are much higher than that at 44.9%. The obesity rates come from various reasons in African American women. So some of those issues can include living in a food desert in areas where they're not able to get the fresh fruits and vegetables. Sometimes the environment is not conducive to be able to engage in physical activity every day. Also, African American women may not view themselves as obese, so their body perception is different. Their perception of their body image is different. So I'm completing my project in a primary care clinic in the southeastern United States, where a little over half of the population served are African American women, and approximately 50% of all African American women are obese. BMI counseling, not standard or comprehensive here was recognized at the clinical site, which prompted me to do this project. Quality indicators include Healthy People 2020 and Centers of Medicare and Medicaid, better known as CMS. Healthy People 2020 has an objective to reduce the proportion of obese adults to 30.5 and to set CMS has set adult core measures for clinical quality to document BMI and to have follow-up documentation when the BMI is outside the normal parameters. As you can see here, the goal for Healthy People 2020 is 30.5%. However, at the site, their African American women are at 50%. So there is evidence that supports translating a frame text messaging into practice among the population of African American women to promote weight loss behaviors. In reviewing the research, I have found that 2 systematic reviews support using text messaging and tailored text messaging for behavioral weight loss interventions. Also, there are 2 evidence-based guidelines that support weight loss behavior specific to nutrition and physical activity. I also found a randomized controlled trial and quasi-experimental study that supports tailored text messaging in predominantly African American women, and they had positive findings. And lastly, a cross-sectional qualitative study which suggested that African American women are willing to participate in technology when addressing health conditions. The purpose. Literature indicates a gap with respect to representation of African American women in weight loss studies and with text message interventions. For this project, I used frame tailored text messaging as the proposed solution. It's a customized health communication approach that fits beliefs and the needs of target population. This pilot project aims to evaluate the feasibility of frame interactive theory texting, also known as FIT, and its impact on weight loss behaviors in adult, obese, African American women in a primary care setting. So my clinical question is, in obese adult African American women, does FIT compared pre-post match cohort affect weight loss behaviors over 12 weeks? To address my project, I used the QI approach that I use is the FADE model. It has 4 phases: focus, analyze, develop, execute, evaluate. My focus was on disproportionate rate of obesity in adult African American women at the clinical site. And I used the EMR to to analyze the situation, and it revealed the opportunity to standardize obesity counseling and offer intervention between visits. So going back to the research, I was able to find evidence of a framed text messaging protocol to be implemented. And to execute, the plan was to implement the intervention at the practice site and evaluate outcomes. So a little bit more about the FIT intervention. Weight loss counseling uses standard and comprehensive educational leaflet. Also, framed interactive theory texting, like I said, is better known as FIT, identifies motivational orientation with a questionnaire. Then participants receive framed messages matching their orientation. Promotion orientation receives a gain framed message using words such as reward, continue, check, monitor, reach, help. Prevention orientation receives loss frame messages, and it uses words such as prevent, failure, risk, avoid, steer clear, and do not allow. The overall content of the text messages focuses on diet, exercise, and self-monitoring. The messages Um, Also can be push messages where just delivering the content, or pull messages where a response is requested. Here's an example of the messages that they will receive. This is gain framed, so you can see that check is highlighted because that's one of the key words to use. Here's an example of loss frame, and you can see where prevent is highlighted as one of the key words. The outcome measures. Uh, for outcome measures, I'm looking at weight loss behaviors. So I will be using weight control strategy scale, which is a 30-item survey that will be given, and it has 4 subcategories. Is dietary changes, self-monitoring, physical activity, and psychological coping. I will also be tracking weight, BMI, and waist circumference. So on to implementation. As I said before, this FADE was my QI approach to this project. I was able to make it through focus because I was able to find the problem here at the site, that there was a disproportionate rate of obesity in adult African American women. I also analyzed the situation, and I revealed there was opportunity to standardize obesity counseling and offer intervention between visits. So the problem came when I got to develop. And based on the evidence, a frame text messaging protocol was developed for implementation. So once I got to that point, I was not able to execute. I was not able to move forward. Some of the implementation barriers that I ran into was in the innovation, system antecedents for innovation, and system readiness for innovation, and adopter. So this particular chart is the diffusion of innovation and service organization conceptual model, and it offers perspective and discriminating major implementation barriers and challenges. This site priority areas are with innovation itself, system antecedents, and system readiness and adoption. Implementation, some of the implementation barriers included innovation capability, weight stigma, and adopter motivation. Innovation capability was a concern as there was some degree of hesitation in discussing weight loss that may stem from provider and patient-related stigma. To mediate this, the plan was to train clinicians in a brief evidence-based weight loss counseling approach with a practical and matter-of-fact manner. However, I was never able to reach that point and ultimately attributed to innovation incompatibilities to possibly be rooted in adopter, which was motivation. So when I reached the system, looking at system antecedents for innovation are specific to the site's absorptive capacity of new knowledge. Translating research to practice with the site's existing underutilized technology poses a challenge. Historically, the site is accustomed to clinical trials as compared to translating evidence into practice. Furthermore, the site has never used the electronic health record text messaging feature. Providing targeted support that builds upon the site's existing knowledge and skill set will be pivotal while engaging champions and key stakeholders who will assist in streamlining the process. The other area of system readiness, where we're looking at staffing patterns and demands. System readiness is an issue given staffing patterns and demands that may impact the site's ability to dedicate time and resources. Attention will be given to the structure, the innovation in a manner that minimizes the use of staff while avoiding additional staff burden. So as you can see, there were more barriers than strategies. Strategies were implemented, however, this site needed a little bit more than what could be offered at the time. So some of the lessons learned. There's under recognition of weight stigma and implicit bias halted implementation. So, and there was an opportunity to instead implement an intervention to manage stigma and bias. So they're just going back and recognizing that there were more issues in regards to the stigma and bias where possibly so there were more issues in regards to stigma and bias, and possibly if recognized sooner, I could have maybe tried to destigmatize the practice instead of kind of like just jumping into a project that focused on obesity. So some of the issues that probably could have been addressed is actually looking at the environment and seeing if it was appropriate for obese patients, making sure that everything was available to obese patients. Also speaking with staff and other professionals there and possibly having some type of teaching for them. So all those things I believe should have been probably recognized early. Any questions?
Okay, good job.
No,
Your
good job.
timing on this was really good. I think this was an appropriate length with respect to how long you're actually presenting. So you're going to end up between 15 and 20 minutes, which is really good. I'm gonna leave the recording on as I go through the feedback. Is that okay with you? I'm doing that in case you want it recorded. If not, I can stop the recording and then you can just take notes on the feedback I give you. What works better for you?
We'll leave it on.
Okay, sounds good. So at the end, I really didn't expect you to, since we're on the slide, I didn't expect you to make up those other two. I want you to be informed, to do the reading that we've discussed, so that again, here you're just putting a couple of sentences, but behind that is a lot more. What is your schedule tomorrow?
I have to go do my graduate assistant stuff, but I'm gonna see if she'll let me just do maybe half a day because
Okay.
this I definitely need to put in some more time. So
You do, just to clean up some stuff and provide some clarity. The reason why I asked is because I think it's important that you also get another opportunity to rehearse. We can certainly leave our meeting as scheduled at 7 if that'll give you time to do what you need to do, or if there's another time during the day where you feel like I've gotten the information together and I want to run through it, we can do that. So that's why I asked. So one of the things I want you to be mindful of throughout, and you'll probably need to go through and maybe look more so at your notes, because I think that's where this is coming from. You speak about this experience as though you're planning it as a student. You can speak as a student, but everything at this point should be in past tense. So there were some times where you said, I will do this, or we will do that. You already did it. So I need you to go back and make sure that you're reflecting what's already been done and not talking about what you will do. Okay?
Okay. I think that's just the way I'm talking because I didn't even, thankfully, I didn't even read my notes until I got to that part where,
Yay! Good job. Good job. So you're informed and you have it. It's just figuring out and being comfortable with what you're saying and how you want to say it. So good job. But I want you to speak in past tense, versus we are going to plan or we will plan. You're way beyond that. Okay. Question for you. So I know you have the slides here, and I guess have some content in the notes section. When you write stuff in the notes section, do you write out full sentences? Do you keep it in paragraph form? What does your notes section look like? Do you know what I'm
um,
talking about?
yeah.
Do you
If
put
you're
stuff down there?
if you're referring to like the implementation barrier stuff,
No, 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 no. Let me pull up.
because I didn't read any other things, none but the implementation barrier
No.
stuff. So I don't have any
Oh,
other.
okay. 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 So you don't have any other notes, period. The reason why I was asking, is I didn't know how you structure that. So if you
The
do
reason is
have,
I can't see my notes on the screen. So
right, and so this is why you always have it printed. Um, yeah, you always have your PowerPoint printed, so make sure you do that. And if you have notes, it'll show up, you'll have it in front of you because you'll print it in the notes format. But I'm asking because sometimes when things are in a paragraph form, and actually, um, okay, I want you to stop sharing for a minute and let me, even though what I have is not exactly current, um, I'm still going to pull it up because I want to show you what I'm talking about.
so I mean I do have notes here and I would just write little stuff, but
Right. Keep it
I didn't
simple.
read it.
Okay, that's fine. I want you to keep it simple because, like, have your keywords, whatever's going to help you flow through your discussion. That's what you put in the notes section. Because otherwise, when you go and start, if you were to have paragraphs there, when you go and start doing that, it, yeah, oh, okay. It gets to a point where, you get fumbled and you get lost. So you should be able to see my screen, right?
Hmm.
Okay. So like here, and sometimes you may need some keywords to help you keep it together. Like here, when you talk about quality of life, tell me like some of the, it doesn't have to be all 10, but give me 3 things. You talked about mobility. What else?
Um, mental and physical. Well, that's mobility, physical. So mental and financial.
Mental how? When you say quality of life and mental, what are you talking about?
Um, mental leading to mental conditions such as depression.
And the depression stems from issues with what? Depression around issues. Is it body? Where's the depression coming from?
Yeah, it can come from it can come from the body image. If you look at some of like the weight stigma and the bias, it
Okay. So, with respect to quality of life, they have issues with mobility and not being able to move they want the way they want to. They have issues with depression that may stem from their body image, and what else?
um well, we already talked about quality. I mean, when we get to quality care, when they not want to even go to the doctor.
Right. And even when you got to that point, when you talked about quality of care, because I wrote down what you said. Um,
Where
you
providers,
just said barriers and you talked about equipment. And this is where you just need to tell me how. Like, without the fact that I'm familiar with some of the literature that is informing you, I would have no idea what you were talking about. If you said equipment keeps it, like, you have to be real plain. So with quality of care,
so
you
talking about
have,
like the exam tables, the gowns.
right, and so that I don't know what you're talking about. So barriers, um, there you go. Three things, always three. You hit three, you're good. That way you're giving people an idea of what you're talking about. And so when you talk about stigma and bias, I think you talked about providers viewing them as lazy. I think you said unmotivated or something like that, right? Okay. You also talked about where did you have embarrassment of being weighed, something like that. Um, and
I re-
I don't know how to spell that word.
it's all right.
Whatever it is that helps you to have what you need as a reference, because a lot of times when you write stuff out like this, that's helping you demonstrate mastery anyway, because you're getting together. When I talk about quality of life, what exactly do I want to say? Because you may
Okay.
mention three different things in two different presentations. You get what I'm saying?
Yeah, because that's exactly what I've done.
Perfect. So I encourage you with some of those key words so that every time you talk about quality of life, I'm going to talk about mobility, and I'm going to talk about depression that may stem from um, body image and something else. Every time I talk about quality of care, I'm going to mention stigma and bias related to provider perspective and patient perspective. And I'm also going to talk about barriers and when I say barriers, what I mean is that these people don't even come in for appointments because the waiting room seats are not appropriately sized, exam tables, gowns, equipment for even pap smears are not the appropriate size. Getting weighed is an embarrassment for them. And these are barriers to care, so they don't come in. You say the same thing every time. And you've got kind of your cue words here in a bullet format to where when I get into these details, it's there. Eric, you have to remember these, how many ever bullets are here. This is like 2 pages of your proposal that you're trimming down to like a 1 or 2 minute spiel. You get what I'm saying?
Yes.
Yeah. So, and then when you print it, you print it in, it's all slides, but instead of the full page slide, you do the notes pages, and then it prints with your slide at the top, notes at the bottom, and that's what you have in front of you.
Okay.
So then that way, if you need to look at it, it's there, and you can go quality of life, mobility, depression, and you're not reading and trying to figure out what was I talking about here. That's my suggestion.
Mm-hmm.
Okay. So for content, okay. So we talked about that. And that was the other thing I was saying with when you talked about barriers. I want you to go back and listen. Maybe when you're driving to Winston-Salem tomorrow, just go back and listen. But when you talked about barriers, you just said something about equipment. And again, I don't have the context, and you have such rich context to speak from. Here, yeah, again, same thing. When you talked about various reasons can lead to less focus on weight management. What I encourage you to do here, because again, you're trying to focus on a subgroup, I think you should present it, or that what you say after here should speak. You start talking about neighborhoods and not being able to walk because it's not safe, and food deserts. Those are not things that are common to African Americans. So African American women. So I think it's important to say, they have to, something along the lines that they have to deal with some of the common challenges around weight loss behaviors, around weight management, that include, not being in a safe environment and not being able to be physically active outdoors, or food deserts, and maybe one more. The things that are more specific to African American women include caregiver burden, stress, whatever those top things are.
Okay.
And articulate the fact that this, when you look at what keeps African American women from being physically active or from doing behaviors that are going to promote their health, these are these are their barriers, their unique challenges. And so people understand, again, what they have in common, but also what sets them apart, because that was not clear. Does that make sense?
Yeah.
Okay, good. I just want you to work on your flow here. It was you got a bit fragmented here, and you'll hear it when you play back. And it may be because we added in that BMI counseling component,
Yeah.
like you went
I didn't
straight
even know it was there.
to.
And if you see, that's where I really got.
Yeah, it got broken up. I tried to use a pretty word. I said fragmented because you went straight to reading it, and I was like, okay. But in any event, what you're just saying is, again, what you saw at the site. The site documented BMI, but their counseling wasn't standard or comprehensive. So you're setting up the scene as to what's going on at that site and why they need this intervention, or why they need a intervention. The question I wanted to ask you, do you want the quality indicator stuff first, or do you want it just like switch places, put the QI stuff first, and then you talk about how the site doesn't meet those indicators?
That'd probably be better.
Okay, okay. So I'll switch that for you when I address the formatting change. Okay.
Mhm.
The other thing I want you to do, because somebody may say something, um, I want you to remember that 50% is approximate.
Okay.
Because remember, all your other indicators are at a tenth, and it's the actual numerical value versus being 0. So it would be different if we said 50.3, but based
Okay.
on the source, the fact that that was personal communication, that wouldn't be appropriate. So I would just frame it as approximately 50%.
Okay.
Um, oh, here, I want you to start demonstrating that bilingual DNP PhD language per se. So instead of saying the research that supports, I want you to say the evidence that supports. I think this slide was changed. Initially, you may have said research supports, but I
No, I
want
think
you
it
to
always says evidence, but I just keep saying research.
research. Okay, switch. Yeah, if you can switch it before
Okay.
Friday, that's good. Um, One thing I think is important to point out, and this is not on the slide, we can add it as a cue for you to say it. Where it has the James cross-sectional study and it has the findings, one of the things I noticed from a prior presentation, I think it was your proposal presentation, is that they looked at the willingness or the feasibility of African American women to work with technology, and they looked at least 3 different forms. Text messaging, if I recall correctly, was listed, but it
Hmm.
received the highest um, acceptability rating or something, whatever the term was. I think it was like 73%. And then you had 2 other forms. I don't know if one was email, one was phone call. I don't know what it was, an app, but of
Yeah.
those, yeah. Okay. So I think it's important to recognize that of the types of technology that African American women were asked about, text messaging received the highest acceptability. So do you want me to put 73% in parentheses here at the end of this finding? Or is that something you just want to make a note to yourself?
I'll make a note.
Okay, okay. And I think it's good to say, blah, blah, blah. Those top 3, text messaging was rated the highest or something, however it's framed. Okay. So you'll make a note of that. Good job. We already talked about the tense. Um, Question. On this slide, do you even want the detail here about how you demonstrated these in your project? Because I think when you get to this slide here to show how you demonstrated, I think this is where it is needed more and where it matters more. I think, what do you think? What are your thoughts?
And that's my thought exactly. I was wondering why
Perfect.
I was saying it twice.
Okay, good. So,
So, when I came back to the second slide, I tried not to read it. I just tried to say that this is what I did,
gotcha, gotcha. Good. Why you ain't say nothing?
because I thought that you thought it was best.
And even if I do, you need to be transitioning to the point where this is yours. At the end of the day, this is your project. You lead it. And when you have a different perspective, you need to be able to articulate that as an emerging nurse leader. And you need to be able to provide a rationale. Historically, with me, when I work with students, there were some things, even I think with Kamlambi, that I didn't like that he did. But you know what? He could give me a really good explanation. So, okay, I get it. So this is where you need to be able to provide that rationale. And for the most, you have to get up and do this presentation, not me. So when there are things that'll make it easier, you're gonna have to stand on that, and that's where that term defend comes in. It's all about how you address it. You get what I'm saying?
Mm-hmm.
Okay, perfect. So we will the steps will be up there. The detailed bullets, I'll take that out for you when I reformat the other set. Here, I'm going to ask you to go back. I'm not going to do it. But if there are any other keywords, highlight them. Okay. I say that because, and when you're on this slide, because when I went back through it, there was redundancy by the fact that you were saying the keywords, the key phrases. And so I was like, it's in the next slide. And then I realized we didn't have loss. So I just cut and paste those in. But highlight those keywords, because that's what's going to draw the audience. It'll draw their eye so that they know I'm looking at this, and this, versus you having to leave the slide up for 20 seconds for people to read it. You get what I'm saying? Yeah, so highlight those keywords. And that's it. I would just make sure that when you listen to yourself and watch, you'll be able to see how much time you feel like that slide needs to sit there. It's not 20 seconds. It's not 15, maybe 5 or 7. Again, draw their eye to what you want them to see. I wanted to point this out. You don't have to change anything with it, but I think one of the good reasons for you to talk about some of the specifics that you do around quality of life and weight stigma barriers from the patient perspective is also because you have this subscale for weight loss behaviors that speaks to psychological coping. We'll pick that up more after you finish your project, and probably include something about it in your discussion section. But I just wanted you to make sure that you note those connections with your literature. And does your protocol include anything that is, okay. I was going to say that is motivational, but the motivation component is reflected in the motivational orientation because the messages are framed. And so that kind of links back to psychological coping. Does that make sense?
Yep.
Okay. Those are the types of connect the dots that you're going to do when you get your results and start having to put all this together. So anyway, we already talked about that. On this implementation slide, when you were talking, I realized that, do you want a question mark at develop or do you want a check mark? Because when you talked about it, you talked about development. It was developed. And then you ran into trouble once you got to execute, evaluate.
Yeah, it probably should be. Okay. I mean, a check mark.
Okay, so I'll change that for you. Okay. Okay, this slide, when you talk about it, you did a good job. The only thing is, I think you need to talk about the model first and then hone in on the specific challenges.
You're right, because I didn't get to my notes. I had started, I was flipping to my notes.
Okay.
So I had to say something.
Okay, yeah, because I was like, she didn't even say the title. That's why I repeated
myself twice.
Yeah, because I was like, well, she didn't even tell me the title of this model. Most people should have some familiarity with it. They may not. But I was like, she didn't even tell me the title. Like, shouldn't tell me anything. But then you did, and I was like, the order needs to be flip-flopped. So, okay.
Yeah, I'll have my notes a little bit better.
Okay, that's fine. But the content was fine. When you talk about innovation compatibility, it should be compatibility, not capability, because those are two different things. And the way you talked about it, you did a really good job talking about innovation compatibility and motivation, and adopter characteristics or whatever it is. Do you want adopter to be in red also, or do you want to leave it in blue? Because when you talk about it, you talk about it as though it wasn't so much a sub challenge, but it was one of your primary challenges. What do you think?
I think it was in blue because I didn't elaborate on it, and I still, if I had to elaborate, I don't think I will be able to
The
explain
way
it
you
better.
spoke about it, you did elaborate because you're talking about adopter motivation. Now, you do need to clean this up. One of the things I'm going to do where it has at the top, it says implementation barriers and strategies. I'm going to have this slide just say implementation. I'm going to put barriers over the arrow on the left, and I'm going to put strategies over the arrow on the right. People should be able to tell which one is the barrier and which one is the strategy, but just so that it's super, super clear. The way you talked about adopter, and again, you're telling the story. You're not, so, realizing that, and this is where you've got to flush it out. From my perspective, based on how you've taught me, I can recognize that the innovation wasn't compatible because with relation to the environment and the adopter or the adopters, there were issues with weight stigma and bias. And actually, I could probably just put innovation compatibility and adopter, and I could put weight stigma / bias in parentheses up underneath the two of them. Do you think that would make it easier?
Yeah.
Okay. So we'll revise that one. I think that, because that's how you framed it. That the innovation was just not compatible because of the challenges with the environment and the clinic staff related to weight stigma and bias. And you can put that, when you're talking about this again, this is where I want you to think about it from a story. So I recognize that the innovation was not compatible, and there were challenges that had to do with the motivation of the adopter that stemmed from weight stigma and bias. And so my approach was to train clinicians in a weight counseling approach that was evidence-based, it was brief, it was practical, and it was matter of fact, in an effort to destigmatize, or in an effort to address some of this weight stigma and bias. That was your plan. So again, this section is talking about the challenge and what I either did or planned to do. Does that make sense?
Yeah.
Okay. So that's where you're going to be here, and that's where this is going to get smoother for you. You recognize that it was an issue based on the literature, but you felt like the approach that you were going to put in place would address it. But later is where you highlight the fact that you didn't recognize it was a major issue as it was until you actually got down to implementation. And the same here. There were also challenges with system antecedents. For example, just like you said, they're used to clinical trial research. This was not that. And so it was difficult for them to wrap their approach. I don't want to say wrap their brains, because Then you kind of insult them a little bit. But it was challenging for them to grasp the different in the approach. And it was also challenging for them, like you said, to use their EMR texting capabilities because they didn't use it for that purpose or that volume or that capacity, however you want to say that. The plan was to make sure I provided targeted support and training specific to answering their questions and informing them more about the process for quality improvement research and research translation, and also to engage the champions and the stakeholders with respect to the quality improvement approach, as well as using technology, because that was your plan. Make sense?
Yeah.
Okay. And then again here, the last major barrier was system readiness. There were concerns with staffing patterns and demands. They had a high turnover rate. And so the plan was to develop the intervention in a way that avoided any type of added workload burden. When you get to this one, it's not that I don't want to say the number of barriers outweigh the strategies. Well, no, that's what you want to say. I think you said there were more barriers than there were strategies. I don't think that's necessarily the case, because for every barrier you had a strategy. I think what is best to say here, or how to frame it, is something along the lines that ultimately your barriers ended up outweighing your strategies, with compatibility and adopter being the biggest issue as it relates to weight, stigma, and bias, or being the biggest contributor. Does that make sense?
Yes.
And then you have your conclusion. And I think that gives you a natural transition. You don't have to read all of these things that you have up there, because you just went over them in the last 3 slides. But just the point that your barriers outweighed your strategies, which is a natural transition to your conclusion, that there was under recognition of the weight stigma and implicit bias that halted implementation. And so this left you at a place, this left me at a place seeing that they needed an intervention to manage their weight stigma and bias, as opposed to focusing on an intervention to address the population initially. You needed to address the structure of care first.
Would would that go back? Am I able to tie that back to where if I actually would have looked at it a little bit better, where they actually wasn't addressing BMI or doing the BMI screenings, or no?
Wait. I'm sorry. You know what? No, this site screened for. They did screen for BMI, didn't they?
They screened, but they didn't have a follow-up plan. They
Which is
wasn't.
why, right? We're talking about Mecklenburg, right?
Yes.
Okay. Which is why you have the BMI counseling, not standard or comprehensive. Okay, I understand what you're saying. You're talking about the fact of, this goes back to
It
provider
wasn't as
bias.
serious to them.
Yes, the provider bias. And this is where you bring that in, and you bring it in from the perspective of, I don't want you to say you didn't do enough. You did what you were supposed to do, but that's why you use the term under recognition. You saw it. Erica, you told me about that particular challenge early on, particularly as it related to who would have been your champion at that time. You talked about the fact that you sense that there's some discomfort there.
Mm-hmm.
You see what I'm saying? You saw it, but you just didn't recognize that it was to the degree that it was. You get what I'm saying?
Mm-hmm.
Does that make sense?
Yeah.
Yeah, so I don't think it was really an issue that you didn't do your due diligence. You did, because you articulated it. And that was the only reason, or one of the reasons, that I remember encouraging you to include something in your proposal, background and significance, around weight, stigma, and bias.
Mm-hmm.
So this is a good opportunity to tie that in under the somewhere how you discussed that first bullet, under recognition of weight, stigma, and implicit bias, halted implementation. Because you can give an example of what you saw or observed, but the fact that you just didn't realize it carried the weight that it did. And that leads you to your next bullet, which is the opportunity is to instead implement an intervention to manage that stigma and bias, and then later focus on, and that can be added, later focus on a text message and intervention for the population. Make sense?
Uh-huh.
Good. And then you would add in, if you wanted to add in something about theory, the theory, you can. But if not, I still want to see one or two bullets that reflect some general lessons learned as it relates to implementation. And I think you can get that from chapter 9. Questions?
No, not at this very moment. I will have some.
I hope going through this, rehearsing it and going through this gives you some added perspective, and it shows you where all you're doing is connecting the dots. And even though this takes time, it makes a tremendous difference when you get up to present, and your comfort and mastery of material, so that you're not getting to a slide and thinking in your mind, what am I going to say? How am I going to say what I know I want to say? And that's where having your key words or whatever down in the notes section, that is a strategy that is helpful for me. I'm not saying you have to adopt that, but I'm saying that that's something that has worked for me. But you got to figure out what's going to help you to know exactly what I want to say here.
Are you able to go back to that other slide that had notes on it that you wrote
Yeah,
out for
all
me?
of them have, well,
That you wrote out.
yeah.
Well, you wrote out quite a few.
I was right
That.
here.
Okay.
Yeah. So yeah, that's there. And those are, again, you pick out, look, you don't have to recreate the wheel. You've already wrote this. It's already in your proposal. Just pull out those key things. If they
I
listed
went back,
7,
but I don't know if I need to go back again. It looked like we kind of got rid of some of the stuff. I might have to go back to an older one where I kind of elaborate a little bit more.
you think?
Yes.
Well, whichever one. I know it's in there. I'm pretty sure it's in there.
Yeah, it's there, but
You may
we
need to,
condensed it so
okay,
much.
I got you. And if that means when we do your write-up at the end, you need to make sure that it's that you make sure it's a good paragraph, because these aren't things at this point where I'm looking for you to write about for 2 pages. These are things you should be able to, if you missed it, you should really be able to add a couple sentences and be done with it, no more than a paragraph.
Mm-hmm.
So yeah, just go back and see.
Okay.
Yeah. And decide what do you want to pull out that way. So those were my things. If you send me the slides, I'll reformat it according to NCNA's request, and I'll get that back to you tonight, and then you can finish making whatever other changes. Because I think at that point, your changes are mostly your notes changes, not your content on your slide changes. So you can go ahead and, if it meets your approval, send that back to Karen.
Okay.
Does
Because I
that
think I
make sense?
sent it back today, but she'll
Oh,
be
you
okay.
already sent it back? Yeah, you know, she'll be all right. Yeah,
Well,
like I
she'll be
said,
okay if I send it tonight, right?
yeah, she should be. Hold on one second. Let me make sure. Hello? Hello? Oh, they already called. I hate those recordings from school. My son's school. But anyway. Okay. Yeah, Karen should be fine getting them tonight. I think the changes we talked about were just a few switches here and there. And I'm really only doing that because I got to change the format. And since she asked us to switch it from wide to standard.
Okay.
Yeah, I mean, yeah. And even if you do change something else before Friday, just have your thumb drive with you. People walk up there all the time with their thumb drive.
Okay.
At least they have historically. They usually have equipment where you can plug in your thumb drive, but otherwise they'll take what you sent, and they just like to have it all pulled up so they can. It's easier transition in between speakers. I'm really looking forward to this. I think
Okay.
this is going to be great.
I'm kind of glad I go at the end of the day.
Why you say that?
Maybe people be done got up and left. Maybe
Well,
half the
you
people.
may. It varies. It depends on how far people have to travel, I think.